Okay, sorry. All right, but we are talking specifically cluster headaches, but mostly migraine headaches, which are a special type of headache related to changes in neurotransmitters, chemicals in the brain that change some of the blood vessels that cause swelling of some of the blood vessels in our brain. And so these headaches can be quite severe. People, it can be a little bit genetic. The people who, end up with migraine headaches, they can be related to hormone changes in your body or stress, but these severe headaches can be preceded by an aura, meaning that the person gets sort of like a warning sign that this type of headache is happening. Sometimes it's like a vision change, even like a little blind spot, or floaters in the vision, or a strange smell, or just like a little bit of a slight headache could be considered an aura or the warning, and then you get the full on headache, which is very severe and causes the patient to really want to retreat to a quiet and dark space because light and noise increase pain. And sometimes people with migraines have confused their migraine headache for a stroke because they can have vision loss and change, and some people experience numbness and tingling at the same time. But it is very severe. The cause of a migraine is different than, a stress headache or tension from muscles. It's because some of the blood vessels inside the brain become inflamed. And because the brain is in a closed space, that inflammation can end up kind of pinching on nerves that are in the brain, leading to the pain. The thought is that there's an imbalance in two neurotransmitters, an increase in what is CGRP, and a decrease in 5-HT, which is serotonin. So, for some reason, that occurs. So, we don't actually know the cause of that imbalance, just that that's what happens that leads to inflammation of vessels that causes the pain. So the medication is aimed at reversing that imbalance mostly by increasing the amount of serotonin in the brain in that area. So how would you treat migraines? It depends on how frequently the person has migraines. Sometimes they only have them every now and again, and sometimes they have them so frequently, maybe weekly, a couple times a day, that it hinders their daily life. So if they're having very frequent migraines, they could consider being on a medication every day to prevent them from happening. And those are often medications that are in different classes that have been found to help prevent migraines, like beta blockers, which we studied regarding blood pressure. We're going to talk about anti-seizure medications and antidepressants next class, but some of those same medicines can be taken daily in order to try to decrease the chance that you're going to get a migraine. Otherwise, treatment is described using the word abortive medication. So you're trying to abort or stop a migraine from completely forming. So you get that aura or some small symptoms that are usually what occur when you're going to get a full migraine, and then you take this medication to abort or stop the migraine from fully developing. So these are medications that are taken as treatment for migraine headaches. They are serotonin agonists, meaning they act like serotonin in the area of the brain where serotonin is depleted, which is causing this inflammation. So we're bringing up serotonin to try to decrease the inflammation and change that ratio. And there are multiple ways that a person can take these medications. This large family of migraine medications are called serotonin agonists, and they're the triptans. That's the name of the family. The medications end in tryptin. Sumatriptan is Imitrex. That's the first medication of its class. That's our prototype medication. So sumatriptan is what you will see on the exam. And it can be given in multiple ways. sometimes people pick different ways based on whether or not their headaches or their migraine headaches cause nausea. Because for some people it does, and then taking a pill is not going to be effective for them if they throw it up. But you can take a pill, PO1 tablet, and then repeat in 2 hours if the headache is still present. Or you can take as a nasal spray or subcutaneous injection. The nasal spray is one spray in one nostril, and then that can be repeated in 2 hours if needed. The sub-Q is give once, can repeat in 1 hour if needed. You'll notice that all three ways you could give a second dose, but only a second dose. That's the max. And that'll always be a question because that's really important to educate the patient. If you're still having a headache after the second dose, then there's no extra triptan that can be taken because you could get too much vasoconstriction. So you cannot take more than 2 doses. The side effects of sumatriptan are chest heaviness, tingling sensations, and dizziness. So that is just feelings that the person experiences, just so they should know, like that you're going to feel that, but it's not dangerous. It comes with the medication. However, what we're worried about is if the patient gets severe vasoconstriction and they end up having too much, an increase in their blood pressure, which is too much pressure, for their heart, leading to angina or some kind of problem with their heart, or decreased blood flow to their brain, leading to issues with stroke. So that is why you can't take more than 2 doses. So side effects are chest heaviness, tingling sensation, and vertigo. Adverse effects is severe hypertension and decreased blood flow to the brain. And then the last effect that we have to worry about is if we end up with too much serotonin. There's this syndrome called Serotonin Syndrome. So we are trying to increase serotonin in the area of the brain where serotonin is decreased, causing an inflammation. However, if the patient is on other medications that manipulate serotonin, you could actually end up with too much serotonin, and then the patient will develop serotonin syndrome. And this will come up again next week when we talk about antidepressants that manipulate serotonin. We have talked about one medication in the first unit that changed serotonin. It was a pain medication. Does anyone remember what that was? Is a centrally acting weak opioid pain medication that's main effect was the change in serotonin. No, naloxone is the opioid antagonist, so that helps block or reverse opioid actions. This does have a tiny amount of opioid activity, meaning it is an opioid agonist, but its greatest activity is its increase in serotonin. Tramadol is the answer. So say the person took tramadol for headaches, they would have to be they would have to be careful about adding another medication, um, that also manipulates serotonin, because too much serotonin in the beginning could lead to chills and diarrhea, but in the end could lead to fever and seizures, which could potentially lead to death. So here are the possible causes
Can I ask a
of
question?
serotonin. Yeah.
So I don't like taking tramadol. Like when
Yes.
I take it, like when I try to sleep, it's like I can never fully sleep, like go into like a REM
Mm-hmm.
sleep. Is that a normal, like,
Mm-hmm.
does that have anything to do with that?
It may a little bit. Some people do experience insomnia with tramadol, and it might be related to the serotonin changes. It's possible because it could go either way. It could make you lethargic or insomniac.
Oh,
So I just wanted to clarify on the tramadol. So you can't take tramadol plus another serotonin um, Ser-
medication.
I'm sorry, what?
Another serotonin medication.
Yeah.
So you have to be careful depending on the dose of the one that someone is taking every day. So the situation where it comes up in my line of work, because I still work as a nurse practitioner in surgery, is
Hmm.
that we like to use tramadol as a post-operative pain medication because there's less addiction potential, but it does manipulate serotonin. There's a large portion of people that are on SSRIs, antidepressants, which are serotonin reuptake inhibitors. So we that doesn't mean that we haven't given it to them. We have said, like, if you feel like you're more dizzy or have increased headaches or don't, then try something else. It's not like 100% that they'll have a problem, but people who try tramadol and then feel sick, they probably shouldn't take it if they're going to take the SSRIs. That's the time that I've seen it the most.
Okay.
So it's
So it's just like a use like
possible.
caution, like if this
Yes,
medication was
exactly.
somebody. Okay. Got it. Thank you.
Yes, yes, sure. You'll notice that, and we'll talk about it again when we talk about antidepressants, is that people who are in high doses of antidepressants have to worry more than people that are on the usual dose of antidepressants, in terms of serotonin syndrome or interactions with other medicines, or if they're on multiple types of antidepressants, they can have some of them have similar actions, so it can increase their risk. So serotonin syndrome is a much greater issue for people that are on certain antidepressants. But I'll just start to bring it up here because this medication does also manipulate serotonin, just like tramadol did. So you never know. Some people are going to be more sensitive to that stuff than others. So that's the end of the migraine thing before we start beginning to talk about nerves and the autonomic nervous system. Does anyone have any other questions so far? So I will shut this one down and we will start with discussion of the nerves and the nervous system, because just like we do with cardiac and the immune system, we kind of have to understand the underlying physiology of these systems before we can understand how medications manipulate them. And this is where I think our textbook does the best job over ATI, by really explaining kind of in a quick way the physiology of these different systems and the receptors that we're targeting. So if any of that is ever confusing, that's a really good place to look. And we always have to remember that we can never do anything that the body can't already do. We can only manipulate nerves in a way that the body already uses nerves. And to understand that, that's this picture, is one way to look at it, is to understand how nerves send signals to the next thing in order to accomplish some kind of task. So there'll be, to draw it in a small way, this might be like the top of the nerve, which is sometimes called the cell body, and then the nerve axon, which sends the message, and the end of the nerve, or the terminal, or the presynapse. And then we have the synapse, which is a space. And then we have the next thing. The next thing could be another nerve that is waiting for a signal. It could be a muscle. It could be a gland. It could be anything. The heart muscle, or some sort, the adrenal gland or something. We don't, it could be any of those things. That, whatever is the next thing, is post synapse. And in the part that's the post synapse, there's going to be receptors. so that when a neurotransmitter is released, it'll interact with the receptor in order to cause something, either to stop activity or to increase activity. So if I'm going to manipulate that, then I will try to go to those different areas where nerves are transmitting from the first nerve to the second nerve, or to the gland or muscle or whatever we're doing in between the synapse. So here's my nerve, the first nerve. An action potential will be sent down, a stimulus. Somehow this nerve was stimulated. There are neurotransmitters that are packaged and ready to be released once there is a message sent to release them. When the message is sent, the neurotransmitter comes into the synapse, and then it can interact with receptors on the next thing, causing some kind of action. And that was the whole reason that that occurred. And then, because eventually we want this synapse to be cleaned out, because we don't want the neurotransmitter to be in there forever, we could never have the next action, some of the neurotransmitter will be recycled, which is called reuptake. Some of it will diffuse away, and some of it will be broken down by an enzyme that's already in the synapse to try to clean it out so it's ready for the next action. And those are all the things that drugs can do in terms of manipulating the action of nerves and neurotransmitters. So drugs could stop the synthesis of neurotransmitters. That's not as common, but that's possible. They could prevent neurotransmitters from being stored into those little packages. Those are called vesicles. It could prevent that from occurring. It could stop the release or influence the release of neurotransmitters, either make the neurotransmitters release or stop them from releasing. It could prevent destruction or reuptake of neurotransmitter at the synapse. So it could prevent reuptake, which is our recycling action, or it could prevent the enzyme from breaking it down. We have many medications do that. Or it could bind to the receptors on the next thing, whether that be the next nerve, muscle, etc., so that even though the neurotransmitter was released, whatever action couldn't occur. So that's where the drugs act. So then we have to review the systems that the drugs can affect in terms of their nerves and neurotransmitters. And so that means the autonomic nervous system, which is our fight or flight response, and our rest digest response. It is the responses of our body that we don't, cause to happen. They happen automatically. And the somatic nervous system or skeletal muscle system are voluntary movements. So it's our involuntary and our voluntary movements. So we have our sympathetic, so now we have to get used to some terms that will come into play. So the sympathetic nervous system, we would expect actions that will help the body in terms of stress. So, and remember, just like when we talked about blood pressure medications, the stress that our body is built for is physical stress. Dehydration, starvation, major trauma, stuff like that. We're not built for pharmacology stress. So everything that happens in response to the sympathetic nervous system stimulation is to prepare us to help us get through these episodes of starvation, dehydration, and trauma, especially protecting our brain from any damage. So the major neurotransmitter that's released when the sympathetic nervous system is activated is epinephrine and norepinephrine. And the receptor that these act on is called an adrenergic receptor. And we've talked about two adrenergic receptors when we went through all the information about cardiovascular stuff, in meaning the alpha receptors and the beta receptors. But collectively, those receptors are called adrenergic. So if a medication acts like epinephrine and norepinephrine on the adrenergic receptors, alpha or beta, then it would be an adrenergic agonist. If the medication blocked the activity of epinephrine and norepinephrine on the adrenergic receptor, then it's an adrenergic antagonist because it's stopping that action. So then you have to think, what is the action? So it's always good, and you should try to, because this is the stuff that's going to be on the exam, sort of consider, kind of go down head to toe, what will be helpful in terms of dehydration, starvation, or trauma. Heart, vessels, GI tract, GU tract. So obviously, if we are being chased by a saber-toothed tiger, it's really not time to go to the bathroom or to urinate, and so, or to work on digesting food. So that is not our goal right now. Our goal is to keep out of trouble. And so the pupils will dilate so that we can see in the dark. Our mouth becomes dry. There's decreased salivation because we don't have to, we're not worrying about digestion. The bronchioles will open up, so we'll have bronchial dilation so that we can get more oxygen in. The heart rate will increase, and the blood vessels will constrict because we want to be sure we get enough oxygen around to the body, especially to the brain. So we will peripherally constrict our blood vessels, sacrificing the peripheral body in order to be able to give blood to the brain. And we will decrease GI and GU activity. So that means the person will not urinate. We stop that process, and we decrease GI motility, so we stop that process. So say the person is taking a medication that acts like the sympathetic nervous system. It is a sympathetic nervous system agonist or an adrenergic agonist. What are some patient education points that you'll need to give them, or things that you'd be worried about with patients? If you looked at those things. So metoprolol and labetalol are examples of adrenergic antagonists because they're blocking the activity of the sympathetic nervous system. So we would have the opposite.
Do you want examples of medications, or are we talking about symptoms somebody would have if they were taking that?
Talk about symptom management. So we haven't officially talked about alpha and beta agonists or medications that would activate the sympathetic nervous system. They're actually used in the respiratory system. They're respiratory meds. Now, I could give somebody pseudoephedrine, which thins out nasal mucosa and helps the patient breathe, or I could give them albuterol, which dilates bronchioles. But then the patient may potentially have other side effects or adverse effects related to sympathetic nervous system stimulation. And so then I would need to tell them about that.
So are you saying like an example would be that if somebody was taking a medication that mimicked that like an example would be they would have like a higher heart rate normally? Or I'm just not getting to the question.
No,
okay.
You are totally getting it.
Okay.
So if they have the potential to feel palpitations, which happens when people take albuterol.
Okay.
So I would let them know that. What about if someone's taking a medication that causes pupil dilation? What would you tell them in terms of driving?
Don't drive.
Well, well, specifically when would you worry?
At nighttime?
It's dilated.
So the pupils are dilated, so that means you're letting more light in. So if I'm
And
driving
then
during the day, yeah, I'm not going to be able to see. So they would need to wear sunglasses or not drive during the day. Yeah, or wear sunglasses. Does that make sense? So we're trying to figure out what you would tell patients then, just like we've been doing all along. It's just now it's a different system. So if I have taken a medication that is potentially activating the sympathetic nervous system, what type, what potential problem are you worried about? And what I'm talking about is here, knowing that this can cause vasoconstriction, is there a certain type
high
of
blood
patient?
pressure.
Exactly. So if someone is hypertensive, they might have to worry about taking a medication that activates the sympathetic nervous system. What about this? Will they be constipated or will they be have diarrhea?
I would think constipated because they aren't like, it's not going out of their body, so it's building up.
Exactly, exactly. So then we would have to be sure that they were drinking lots of fluid because they're already going to be dry, that they are getting enough fiber. So just kind of thinking about, and this is kind of what this is not kind of, this is what the quiz will be about. What if I'm taking a medication that activates the sympathetic nervous system for whatever reason? I can expect that these symptoms are all possible. All these things are possible. And so, what would I tell the patient? Or what would I be concerned about with the patient? So, okay, we have our adrenergic receptors, and norepinephrine and epinephrine is the neurotransmitter, and it's acting like the sympathetic nervous system, so it's miming or acting like it's their adrenergic medications. So that's terminology. This is what we just said. The pupils will dilate, salivation is inhibited, heart accelerates, lungs dilate, we decrease digestion. All of those things occur, so that's why we tailored our um, teaching about it. So there is an enzyme that works, in that synapse. So medications could stimulate the release of the neurotransmitter. They could um, bind to those receptors and act like the neurotransmitter, or block the neurotransmitter, or change the activity of the enzyme in that area. So if we are acting on adrenergic receptors, we are either an adrenergic agonist or adrenergic antagonist. That's the main words to know. We've talked about alpha beta in the cardiovascular unit, but what we really want to know is if I'm an agonist, just like in the first class, if I'm an agonist, then I'm acting like the body. If I'm an antagonist, then I'm blocking the body. So the next thing, which we'll just briefly start on because it's just about time for lunch, is the parasympathetic nervous system. And this is the opposite of the sympathetic nervous system, but it's not completely rest. It's just a different priority. We've changed our priority from um, trying to conserve oxygen and glucose to the brain. Instead, we've decided that we're good. Now we can eat, digest our food, urinate if we have to, take up care of other issues. So these receptors are called cholinergic instead of adrenergic, which is the sympathetic side. These are cholinergic receptors, and these receptors, the neurotransmitter is acetylcholine instead of epinephrine and norepinephrine. I did not spell that right. Acetylish choline, something like that. And then we are, if we're acting like the parasympathetic nervous system, we are a parasympathetic mimetic. But these are cholinergic medications. On the other side is adrenergic medications. So we'll stop here. We come back at 1 o'clock. We'll talk about what happens to the body if the parasympathetic nervous system is stimulated, and therefore what are the directions we would give a patient if that was the case, because that's the other side of what could be on the quiz. So I will see you guys at 1 o'clock after lunch.